Good evening, everyone. It it really gives me a lot of pleasure to start this meeting today. Um, this is a new academic activity that our team has started as part of the International Hematology Consortium. We are going to have a hematology club, a monthly academics last week of every month. Incidentally, the first one we have two. So that's one is today and the second one will be next month. We felt that we are not having regular academics in the city in our specialty. And this would be a good way of looking disease-wise at each disease, have a very simple format, one seminar and one case discussion. And with that, try to get a glimpse of where hematology is and what we're looking forward to. Serious thanks to all of you for making time today evening. You're all busy after work. You've come here, and I'm hoping that this will be worth your while. We are going to talk about a drug called Adcetris, and this is essentially brentuximab. Yeah. Can you hear my sound? Sorry. So we are going to talk about this drug, brentuximab. And my association with brentuximab started by hearing about it when I was training in Canada in 2011. Before that, if we look at immunotherapy, and by immunotherapy, I mean that the cancer cell has a particular protein, which is antigenic, and we make immunoglobulins, we make antibodies against it. With this, the hope of immunotherapy is that we will be able to specifically target the cancer cell and kill it with minimum side effects. Now, this concept divides oncology as a specialty into two eras, two separate eras. If we look at the beginning of oncology, and in fact, incidentally, this drug brentuximab was first used for Hodgkin lymphoma. At the same time, well, not at the same time, but interestingly, the first combination chemotherapy by Dr. DeVita was also created for Hodgkin lymphoma. So Hodgkin is a very important disease for hematologists in terms of the historical perspective. So what Dr. DeVita did is we knew in the sense in science, it was known that, you give some drugs, your heart rate goes fast, you give some drugs, your heart rate slows down, your blood pressure goes up, blood pressure goes down. But at the same time, it was known that some drugs are toxic. And by toxic meaning they can kill certain cell types. It was also found out that there are certain chemicals which are eaten up by cells that are rapidly multiplying. So any cell that is multiplying fast will chew up certain chemicals. And if that chemical is potent enough and toxic enough, it can kill that cell. That's the core concept of chemotherapy. The core concept of chemotherapy is you give a chemical which goes through the blood, which goes to the cell chews it up, it is toxic to the DNA, and the cell dies. Yeah. However, any other cell of the body, including a normal cell like hair follicle, GI epithelium, all of these are also rapidly dividing. And even these cells will chew up the chemotherapy and die and cause side effects. So these are normal cells getting killed. The side effects being mucositis, hair loss, blah, blah, blah. And, including normal bone marrow getting killed. But that was the extent of knowledge, that there are some chemicals which can do that. What Dr. DeVita did essentially is he combined four such drugs and made a protocol, made a regimen, and showed that a combination of these four medicines cured more patients with Hodgkin than giving single drugs. But nevertheless, they're still just chemicals which are blindly killing rapidly dividing cells. Yeah, they cannot target cancer cell. But then this was a huge leap in treatment, nevertheless. And this worked for several decades, maybe 50, 60, 70 decades. This worked. However, patients and doctors and oncologists kept on feeling why side effects and how much can you give? And what do you do when the cancer comes back? Do you keep on giving more chemicals? Well, you have to. And people try to find newer medicines which are toxic, but they'll work with through a different pathway and they'll work on relapse, refractory, etc. So when we joined hematology, right? And when I joined hematology, there were only two medicines which were known as targeted therapies, only two drugs. Everything else was chemo, right? Blanket treatment, it will kill cancer, it will kill normal cell. These two drugs were imatinib. Yeah, great, thanks. So there were only two drugs which were known to be targeted. One was imatinib, specific for CML mutation, and the second one was rituximab. And what rituximab did is it got attached to CD20. CD20 was a protein on the cell surface of some lymphomas, and it changed everything. Overnight, there's targeted therapy, and we all thought that great, now targeted therapy is going to come up, all tumors are going to get cured, mortality will be minimum, side effects will be minimum, and five, six, seven more targeted immunotherapies came and failed. They failed. They failed to kill enough cancer cells, prevent toxicity, blah, blah, blah. Nothing was working until this drug, brentuximab vedotin, came in. Now, brentuximab vedotin is an anti-CD30 drug, okay? And sorry. So it is an anti-CD30 drug. The CD30 is another protein on the cell surface found in Hodgkin again. You see the first chemo combination in Hodgkin, and after DLBCL, we are getting this CD30. And it was thought that maybe this will work. And trust me, it's pure luck, because so many different drugs were being tried for so many different antigens. After rituximab, truly nothing was working much. It just clicked. Now, when this worked, incidentally, the research was being done by Joe Connors in Vancouver, Canada, and I was fortunate enough to be training in that department at that time. And Joe is the authority on Hodgkin lymphoma. He has collected data over the last 30 years and tried to figure out which patients to treat in what way, analyze thousands of patients, really beautiful work. And he used this CD30. It's a combination, brentuximab and vedotin, and it gets attached only to the cell which expresses CD30 and kills it. Only the Hodgkin lymphoma cell, no side effects, except the vedotin also affects the nerves, the peripheral nerves, right? That was the only side effect. And what was done is we were using ABVD chemo. He added this to it. And there was horrible neuropathy. Then he realized that ABPD has vinblastine, which is also neurotoxic. Maybe I removed that, right? So he removed vinblastine and AVD plus Brentax. Beautiful, beautiful benefits, no neuropathy. And that's how science evolves. It evolves by trial and error, and it evolves by fluke, right? So everybody uses their brains, tries to do things intelligently, but you never really know how things are going to go. Now, Hodgkin lymphoma is considered in oncology to be an extremely curable cancer, extremely curable. If you catch the patient early, diagnose in stage 1, 90% get cured. If you catch them late, 70% get cured. If there is a relapse, you can still cure 60%. So the question truly was, how much is this going to help? It's already such a curable disease with very cheap chemotherapy. And I remember he did not use it for stage 1 first. He used it for advanced Hodgkin, where the cure rates were 70%. And I was sitting in the hall when he presented the data to the hospital, and 70% has become 90%. And he said, look, there's nothing more that we can do in cancer. That was the magic of this drug. So multiple combinations have been tried, multiple studies have been done in Hodgkin as to when to use it, at what dose, when not to use it, whom does it really help, whom it doesn't help. One major thing is Hodgkin happens to, occur in the young. So in young patients, we don't want to give too much chemo. We don't want to give too much chemo. So maybe we give immunotherapy so they don't have long-term cardiac toxicity, second tumors, etc. That is what was happening. Now, while this was being used for Hodgkin, of course, doctors were thinking, hey, you know what? There are some other cancers as well which express this CD30. Why not try it out? Why not try it out? And around 2000, I think, 10 onwards, we started getting case reports. Some patient has CD30 positive lymphoma, something else, not Hodgkin, non-Hodgkin lymphoma, not responding to anything. And they tried this. Some patients benefited, some didn't. And that's where we realized that once we have a good molecule, once we understand the benefits and the side effects, and now we have started, in 5-10 years toxicity profile, why not use it for other drugs? And that's what we are going to talk about today. We are going to talk about how brentuximab helps in other non-Hodgkin lymphomas, especially T-cell lymphomas, T lymphocytes. Non-Hodgkin lymphoma can be B or T cell. B cell, better cure rates, medicines work well. T cell have traditionally been horrible. A lot of patients don't get good response. Even if they get, the cancer comes back. How does this help? So the T cell lymphomas are broad category. There are about 25 different subtypes of T cell non-Hodgkin lymphomas. Where do you use? Right? The lymphoma may be in the node, it may be outside in the node, it may be on the skin, it may be in the blood, in the leukemic phase. Which one of these should this be used? Right? Maybe what should be done is those which are commonest, we should first try on that. So there may be maximum benefit. So essentially what was done is by looking at the different types of T cell lymphomas, and the commonest is called PTCL, peripheral T cell lymphoma. Peripheral T cell lymphoma, not otherwise specified. That means it can't be classified anywhere, right? PTCL NOS. Then you have this angioimmunoblastic, which was horrible. I remember the first patient that I saw, young lady from West Bengal, lymphoma would come back in between cycles. So you give chemo, it goes away. Before the next cycle, it comes back. We did an autologous transplant. Within 4 months, it came back. We did an allogenic transplant. It was controlled for some time. So AITL, bad disease. ALCL, anaplastic large cell, ALK positive, great disease. Great disease, lot of patients, especially young children, get cured with just chemo. If this ALK is positive, this is a kind of a lymphoma kinase, anaplastic lymphoma kinase. ALK negative, not so good. But these are the large bunch of T cell lymphomas which are common, PTCL, AITL, ALCL, etc. And it was thought to do a clinical trial for this. What is also important is, yes, CD30, you have an immunoglobulin against it, right? And CD30 is expressed on the cell surface, the molecules. But different patients have different number of molecules on the cell surface. Not every patient is same. Not every patient's cancer is same. Some may be CD30 positive, some may be negative. Positive meaning 1% of cells express. In some patients, 50% of cells may express. So the question is, will it work better? Will this work better if CD30 is positive in maximum number of cells? Logically, yes, right? So that also has to be looked at. We don't want to give medicines to patients in whom it's not going to help. It's not going to work. It's a waste of time and money, right? So these are the questions. These were the questions as to, can we get the pathology proper? What kind of T cell lymphoma it is? How much CD30 should be expressed? How many cells should be positive in the biopsy, etc., etc. And then what about current treatment? Why try something new? That's because we know that in T cell lymphomas, like I said, long-term cure rates are not great. If I have 100 patients today, even if they respond to my combo chemo, combination of chemo, right? Half of them are going to relapse. You follow people long enough, they start relapsing. And long-term cures, 1/3. So only about 30% of T cell lymphomas are actually cured in the long term. So certainly there is, a need for some novel therapy. And I told you have different cure rates, survival rates, etc. So what was done is take those T cell lymphomas where CD30 is expressed, and let's try anti-CD30 therapy. If you look at the current guidelines, today this is becoming standard, right? Using brentuximab in T cell lymphomas. But let me tell you how we have reached this level of understanding of change in treatment. Yeah. And that's where we come to the Echelon 2 trial. A large phase 3 randomized control trial was created to see if this brentuximab is added to standard chemo in T cell lymphoma patients who have this CD30. Will this anti-CD30 help? Yeah. Compared with just standard chemo and adding the new immunotherapy molecule. Various common T cell lymphoma subtype of patients were included. They were enrolled. And it was thought, let's see how many get cured, in how many it controls, and in how many the cancer comes back in both the arms, standard versus standard plus immunotherapy. About 500 patients were enrolled, 450 odd, half each in standard chemo arm versus chemo plus immunotherapy. They're practically identical in terms of the demographic characteristics, in terms of the stage of the disease, the type of the disease, etc. What was found essentially, what was also important is the new immunotherapy. How many can continue? Does it cause so much side effect that many patients just can't continue it? Well, if you look at it, actually more patients who got immunotherapy continued the full treatment, because if we just give standard chemo without immunochemo, if you give standard chemo, there were relapses even before the treatment got over. So many patients in the standard arm had to stop treatment because there was early relapse. Right. And ultimately, they looked at how many actually got control and for how long they had the cancer under control. Now you look at the blue line. This is standard chemo. This is what we are used to. We are used to seeing this. We are used to seeing that if you keep on following patients for 6 months, 12 months, 18, etc., up to say 5 years, only 30%, I told you, one third are going to get cured. By adding immunotherapy, it's slightly better. 10 to 20% more patients get cured. So the 30% goes to about 40%. That's about it. But that's big. Why is it big? Because overall, the time that it takes to relapse is doubled, right? In standard chemo, in 2 years, cancer was coming back. Here, cancer is under control for 5 years. How important is it? Well, it doesn't come back in more patients, actually. Less patients relapse, and they relapse much longer, which is important because when someone relapses, we have to give more treatment, we have to do transplant. And if the relapse is early, they've already gone through chemo, then relapse, then we say, no, 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 we have to give more. The body and the mind is not ready to take more medicines. So the more we delay relapse, the greater is the progression-free survival, the easier it is to give subsequent care and subsequent treatment. Now that's where we are with T-cell lymphoma. And overall, if you look at all the different characteristics, the demographics, the stage, the type of lymphoma, it seemed like adding brentuximab to all kinds of T-cell lymphomas was a good idea, except stage 1 disease. Stage 1 disease, anyways, the chances of cure with chemo are so good. It's early disease. No point in adding a new immunotherapy drug. No point in adding brentuximab. Otherwise, everybody seems to benefit. Everybody seems to require less treatment, less relapses, further treatment, everything is reduced. Now, however, they also wanted to look at the, adverse events were not too different. It was fine. It was very well tolerated. Peripheral neuropathy, not too much. I told you some patients can get bad peripheral neuropathy if you, don't give it properly. All of that was fine. It was comparable. Many more, less number of patients relapsed, etc., etc. But what truly is interesting to me is how many cells in the tumor, what percentage of cells should have this CD30 expression for the immunotherapy to work. Yeah. And they divided patients into 3 types. This was a subsequent analysis. They divided patients into those who were negative, meaning less than 1% of cells were expressing CD30 on pathology, on immunohistochemistry, and more than 1%. More than 1%, they said less than 10%, more than 10%, blah, blah, blah. They looked at it, and this to me is fascinating. If you look at the responses in anybody where even 1%, more than 1% of cells expressed CD30, they benefited. And beyond 1%, if 20, 30, 50, 60% of cells also express CD30, it didn't matter. Which tells us that the cancer, the tumor microenvironment is amazing. It's very weird. Even if you start killing some cells, the other cells would also die along with it, even if they don't express that particular protein. So if it's positive, whatever is the positivity, more than 1%, great, it's working in all the patients. On the whole, safety is great. And today we understand that, this has become standard. We add immunotherapy, of course, it's a new medicine, it's expensive. So anybody more than stage 1 who can afford, we should add this. Definitely improves the chances of success. Thank you. Be happy to take questions. Yeah.
Very interesting talk. Not really to topic, not college.
Sure.
But the target therapy and immunotherapy for brain tumor.
I'm not trained in brain tumor. I do know that IDH inhibitors are used, but that's the limitation of my knowledge. I'm not trained in solid tumors. The attendees who are online can ask their questions in the chat box. All right. Nishit, do you want to go ahead with the next?
Good evening, everyone, and thank you for taking out your precious time to be here. Just taking what Dr. Sachin has already explained, we had one patient. So this case presentation is regarding this patient. So there was this 21-year-old female from Africa with complaints of significant weight loss, fever, and all evaluation was found to have classical Hodgkin lymphoma, nodular sclerosis type. In Africa, she was diagnosed. Actually, initially, she was misdiagnosed, and then after a lot of therapies that were given to her, she was treated with 2 cycles of CHOP and then 4 cycles of ABVD. The interim PET showed progressive disease, and then they gave accelerated PSHAP that contains bendamustine, etoposide, cytarabine, cisplatin, and prednisolone. A total of 3 cycles was given, and then she traveled all the way to India for further treatment. When she arrived in India, we did the interim PET, and there was a progressive disease compared to previous. A repeat biopsy was done, and this time a final diagnosis of classical Hodgkin lymphoma was made, and the patient was started on nivolumab, ibrutinib, and bendamustine. After giving 2 cycles, we received partial remission. The areas where there was not remission, we went under local radiation, and then final PET showed the patient is in complete remission. In transplant, since the patient was a young patient and had received around 3-4 lines of chemotherapy, it was decided that we'll go ahead with the hypoidentical allogenic bone marrow transplant upfront, not the autologous transplant. So the mother was chosen as a donor, and the conditioning regimen we used was fludarabine, triosulfan, and TBI. GVHD prophylaxis was PTCY, tacrolimus, MMF, and sitagliptin. After transplant, on day +4, she developed febrile neutropenia. LRTI ball was done, and these were the bugs that was found. But the patient engrafted on day +21, and post which she is being doing okay. So the topic of taking the patient for allogenic stem cell transplant upfront. So as you know, allo is still considered as a curative treatment approach in patients in Hodgkin lymphoma who relapses or progresses after auto. That was the first thought process. The first published reports of allogenic stem cell transplant in patient of Hodgkin lymphoma appeared in mid 1980s. These studies showed a low number of patients and did not offer realistic evaluation of therapeutic potential of the allogenic stem cell transplant. However, two large registry-based retrospective analysis of allogenic stem cell transplant on Hodgkin were published in 1996, and these studies showed a disappointing result regarding the role of myeloablative that were being used, and that greatly hampered and had high non-relapse mortality, and that outweighed the benefits of allogenic stem cell transplant. So to reduce the transplant-related mortality, limited systemic toxicity and facilitate donor engraftment, RIC regimens were used. And the use of RIC regimen in the scientific community was renewed by using RIC protocols that opened the allogenic stem cell transplant to elderly and those with significant comorbidities. The lymphoma, RIC, and myeloablative conditioning protocols, LNW of EPMTA first published a retrospective comparison between patients of relapsed refractory Hodgkin lymphoma. The non-relapse mortality significantly decreased to 23% when we were using regimens for the same, and that was at 1 year. So, although relapse rates were higher in the RIG regimen, the decrease in NRM was translated to better progression-free survival and overall survival. Additional information on the role of RIG allo in relapse refractory Hodgkin lymphoma mostly comes from another large study from LMT part of ABMT, which included 285 patients, which were heavily pre-treated disease with RIG, and then they were treated with RIG allo transplant. The disease status at the time of allo transplant was CR was on 47 patients, that is 17%, chemosensitive in 123 patients, that is 43%, and chemo resistant in disease or untested relapse in 115, that is 40%. And the 100-day NRM was 12% and increased to 20% at 12 months and 22% at 3 years, which is significantly higher in patients who had both chemo resistant in the beginning. So with the 2 years progression-free survival of 29%. So our second retrospective analysis was published, and in this they compared RIG versus MAC protocol of allo transplant over a period from 2006 to 210. That 312 patients were included, out of which 63 had received MAC and 249 received RIG. A median follow of these patients for 56 months. There was no significant difference in RRM between the MAC and RIG. However, the relapse rate were lower in the MAC regimen, 41% to 52% at 24 months. And this was translated to marginal improved of in MAC regimen 48 to 36% in 24 months, with no significant difference in overall survival. This study showed that RRM associated with MAC decreased over time, and the intensity of conditioning regimens should be individualized designed. So this were the data from various studies that from Robertson et al. To they did transplant, and most of them were taken for patients who had undergone prior autologous transplant. However, the next decade became a breakthrough. So somewhere from 2010 to 2020 and what we are ongoing, according to the lymphoma database of there's an increasing number of patients with Hodgkin who are being treated upfront with allo stem cell transplant, and the outcomes of allo transplant in Hodgkin have improved over time. These benefits are likely due to improved supportive care and more effective salvage therapies. Historically, in early days of allogenic stem cell transplant, first transplant after disease refractory to multiple lines of therapy and myoablative was used. However, in younger and fitter, have a shorter interval from the diagnosis to transplant, and reduced conditioning was more frequently used. So allo generally remains a reasonable treatment option who have relapsed or progressed after auto and high-risk Hodgkin, and allo has been demonstrated to potentially be valid as the first transplant in young patient and those with a short time interval from the diagnosis to transplant. So as the years were passing by, then there came the role of CD30 and other targeted inhibitors. The use of newer drugs as a bridging strategy before allogenic is feasible and possibly has allowed to improve the results of allogenic stem cell transplant. A large BMT data showed that use of brentuximab as a bridging to transplant for patients with refractory Hodgkin lymphoma and multivariate analysis demonstrated that pre-transplant brentuximab had no significant effect on the RRM and overall survival. And refractory patients who responded to brentuximab venetoclax achieved remission prior to transplant, obtained advantageous disease status prior to allogenic stem cell, which is one of the most important prognostic factors. There was a French study which included from a period of 2011 to 2013, and 240 patients were enrolled. Among 140 were responders to brentuximab, 54 received consolidation with allo, and the median overall survival, progression-free survival, was 18.8 versus 8.7 in patients who had received remission but did not undergo transplant. And this study suggested that high-dose therapy in stem cell transplant over responders as soon as possible, having in mind short-term responses in most patients. Brentuximab is effective, safe, and manageable toxicity according to real-life study and can be considered to be bridge to transplant. Then another marker, as we all know, is PD, anti-PD-L1 or PD-1, in which when we use that, the median follow-up, nivolumab, median follow-up of 24 months, the 2-year survival in RRM and relapse of 14% and 18% respectively, and the 2-year overall survival was 69 and 82% respectively. This data suggested that anti-PD-L monoclonal is associated with impact post-allo transplant, both in efficacy and toxicity. Patient undergoing allogenic stem cell transplant after use of nivolumab and PTC were used as GVHD prophylaxis as the strategy to improve outcomes. However, this also suggested in the study that all the patients who had received nivolumab prior to allogenic transplant, all of them had grade 2 to grade 4 GVHD, and it also had GVHD when nivolumab was reintroduced as a maintenance therapy. So the other two respective studies, Center of CMBMTR and Haplo, compared the outcomes of haplo transplant with match unrelated donor, match sibling transplant for patients with lymphoma, including Hodgkin lymphoma, 22% of the global population of the patient. In the first study, Cantor was compared haplo with MUD without ATG. And out of the 185 patients lymphoma who received haplo, 46 had refractory Hodgkin lymphoma. Progression-free survival at 3 years was 45% compared to 45% of MUD without ATG, and significantly better than with MUD with ATG, which was at 34%. Haplo transplant had a significantly lower incidence of severe GVHD when you compare that to MUD without ATG. And there's a difference in relapse risk, NRM, in between haplo and MUD transplant, both of them. So another study, they compared a total of 80 patients in brentuximab group who had received a medium of 6 doses of post-transplant brentuximab, compared that to 104 after transplant who did not receive. Although the risk of selection bias was there, that brentuximab was given for a younger patient, that is between 30 to 34, and more likely to receive pre-transplant brent in 65% of such cases, and post-transplant DLI. There was a longer median of follow-up survival in post-transplant patient who was on maintenance brentuximab, and this resulted in complete remission in 29%, partial remission in 45%, and stable disease of 26%. So as I discussed, the nivolumab initiation had resulted in GVHD in all patients who had previously has a history of acute GVHD. So at last, there's a chart of all the patient, and you can see use of brentuximab, the overall response was 75% after autologous transplant, and even it was 72% in patients with allo transplant. So take-home messages: allo transplant is valid treatment strategy in patients with refractory Hodgkin lymphoma because of the improved treatment overall. Newer strategies appeared in this field. CD30 CAR T cell is a promising treatment option for patients with relapsed refractory who progress after prior immunotherapies, including brentuximab and other checkpoints. Anti-CD30 has a high rate of durable response. Overall survival was 72, complete remission was 59, and progression-free survival was 41% in 1-year follow-up. The treatment is well tolerated with an excellent efficacy policy. These are my references. Thank you. Any questions?
So this patient we thought we will present because, like I said in the beginning, Hodgkin lymphoma is considered to be the most curable cancer in oncology. And even in such a patient, and she was a wonderful young medical student from Nigeria. And she had received treatment. Every chemo that she would get, the cancer would come back. And it was just such bulky disease, 10 centimeter nodes and mediastinum. And her father had passed away. She was brought here by her mother, partially educated. And all the treatment was being done by father's friend. who was staying in the US. And the question was, how much are we going to treat? And is it really going to cure? Sure, she's a young patient with, a potentially curable malignancy, but not responding to anything. And we did not really have funds for immunotherapy at that time. It was not available in India. And the question was, should we go ahead and do a transplant on her, hoping that even general concept is before transplant, the cancer has to be under control. Otherwise, it does not work. The transplant does not work if your leukemia lymphoma is, present as a bulky disease before the transplant, except in Hodgkin lymphoma and maybe some CNI patients. Right. In these patients, even if there is some disease on board, allogeneic transplant may work. And we spent quite a bit of time talking to the family, talking to the donor sitting in US, who herself was raising money through church, saying, look, young girl, Hodgkin, allogeneic transplant generally works. And fortunately for us, the family and the donor decided to give her a chance, and we did this kind of transplant. And she's now what 2.5, 3 years post transplant, doing fine, completing her medical education. Thank you. The role of maintenance, we didn't give anything. There was no money. There was no money. Patients have received. Yeah. How long did it take? Well,
So actually we live for 2 years. So yeah, 2 years we did. But by 6th or the 7th month, they suddenly start developing neuropathy. And then we decide if it's yeah.
So Brentex maintenance, even if you look at the clinical trials, I think quite a few percentage, I don't remember the percentage exactly, but a few percentage of patients drop off because of the side effects. Brentex is not great. Nivolumab is probably better tolerated for maintenance. But the GVHD coming out the Nivolumab. Exactly, exactly. And here we completely dependent on GVL. The graft versus lymphoma effect. Sure. Thank you so much. We can wait for it. Thank you. Any questions on the online?